So the majority of treatments of CCSVI are relatively uncomplicated. Stenoses of the valvular area of the jugular veins responds pretty well to angioplasty in most situations. However, there is a subset of patients that really struggle. There are complications that need to be addressed, and then there are patients who have a short-lived response to angioplasty who then go on to return to their sad state of disability. It's a challenging area, and we have different opinions on it, but I've asked Gary Siskin to discuss his point of view about the bailout procedures. Bailout meaning somebody's in the drink and we got to get him out of the water. And his philosophy and strategies towards the repeat procedure.
All right, so this is a tricky one. I have no financial disclosures, so I can move past that. I think when we look at primary procedures, there are a couple things that we think we know. The first is that primary treatment of CCSVI with angioplasty is a safe procedure, and there are a number of studies that have been either presented or published to kind of provide some backbone to that. The other thing we think we know is that treating CCSVI with angioplasty can lead to symptomatic improvement in patients with MS. And obviously that's a debatable point, but there's some, at least some evidence in the literature that's allowing us to think about that, and at least giving some of us partial confidence to say that primary procedures are safe and perhaps effective for treating people with MS and CCSVI. But what about secondary procedures? What about repeat procedures? And I think we could argue right now that we have no idea. We don't know if they're safe. We don't know if they're effective. We simply don't know. And despite the lack of supporting data, patients who have already been treated are coming to us, either people who treated them before or people who are also in this field and are able to offer treatments as well. People are coming for repeat treatments. And they're coming for a couple of reasons. The first reasons are grouped under response-based reasons. So these patients either have had no response after their first procedure, they've had a suboptimal response after their first procedure, or they had a great response after their first procedure, and now their symptoms are starting to return to baseline. So those are some reasons why people may come back for a repeat procedure. The other group of reasons are image-based reasons, and these are people who have undergone follow-up imaging, and these follow-up imaging studies have demonstrated some abnormalities in venous blood flow. I think those of us who've been doing this for a while know that the need for additional procedures is not really a surprise. Rick Gray at a recent VEITH meeting here in New York just gave this nice table in his syllabus contribution regarding central vein angioplasty. And if you just take one quick look at the 6-month and 12-month primary patency rates for venous angioplasty in the central veins, we know that it's not that great. So it's not really a surprise. Zamboni commented on this in his 2009 paper, and we all know the numbers. The 18-month primary patency rates for jugular vein interventions were landed around 50%. And even he commented that it'll be interesting to know when available basically the outcomes of secondary patency in the group of 30 patients who underwent angioplasty a second time. Basically saying, I don't know, we treated some people, we don't know the outcomes yet. And that's really where we're still at when it comes to secondary treatments. So is this a good thing to do? And I'm going to ask that you indulge me a little bit here and get philosophical with me here for a second. So if you look at one procedure, you take a patient and say, okay, is their first procedure okay to do? I think based on kind of the literature, the data that was been presented already to date in this conference, it's probably an okay thing to do. But let's jump ahead to some time in the future and say, what about the 30th procedure in a patient? Is that okay to do? And I think most of us sitting here would probably say it's not okay to do a 30th procedure in a patient. It's probably not okay because just based on our experience with venous interventions, there's probably an increased risk of thrombosis in someone who's undergone angioplasty in the same vessel 30 times, and probably an increased need for stent placement, since at some point along the way there's probably going to be some venous occlusion that happens, some thrombosis that happens, and various things. So it's probably not okay. So if you can agree on that, if you think that procedure number 1 is probably safe and possibly effective, And if you think that procedure number 30 is probably not a great thing to do, then by definition, you agree that a tipping point exists somewhere in that spectrum. And the problem right now is that we really don't know where that tipping point is. Okay, we really just don't. Is it procedure number 5? Is it number 11? Is it 23? Or is it 2? We don't know at what point that tipping point exists. When does this become not a good idea to do? We don't know. If anybody here knows, you can let us know, and we can debate that point, and we can play the Jeopardy music in the background, to kind of think about that. But I think we can argue that in the absence of this knowledge, that we really don't know when the point of no return is for a patient when it comes to these venous interventions. And I think in the absence of this knowledge, I think it behooves all of us to just be careful when treating these patients a second, third, or fourth time. So here's our approach. And I'm not by any way telling you that this is the right approach. It's just our approach. It's what we're doing these days. And I think the core premise behind our approach is that we really are far bigger believers in response-based reasons for doing these repeat procedures as opposed to image-based reasons. And I'll get into that. So when a patient with worsening symptoms presents to our office for retreatment, we talk to them to see if they had a good response or a poor response to the initial procedure. Now, you can define good response and poor response any way you want, okay? I don't think we even have an agreement on what it means to have a good response just yet. I will tell you that, in my mind, I look for a response that led to a significant improvement in presenting symptoms, a significant improvement in quality of life for what I would define as a prolonged period of time. And that's completely arbitrary. I threw up 8 weeks here. I don't know if that's the number to use. Maybe it's 12, maybe it's 26 weeks. I don't have an answer to that. But we're basically thinking about 8 weeks. So that means that anybody else, the people who say, I felt great for 2 weeks and then my symptoms came back, or I felt great for an hour and a half and then my symptoms came back. Those are patients that I would deem to have had a poor response to the initial procedure. All right. Now, these patients, similarly, most likely will have had some type of follow-up imaging exam. So their imaging will either show a good response or a poor response. A good response means good jugular veins look good. A poor response means the jugular veins look not so good. So that leaves a patient who presents to our office with recurrent symptoms after angioplasty as really fitting into one of 4 boxes. Okay? Either they had an initially good response with normal imaging, an initially good response with abnormal imaging, an initially poor response with normal imaging, or an initially poor response with abnormal imaging. That's it. Those are the possibilities for these patients. In general, I will tell you that we have shied away. I'm not going to say we do not emphatically, but we've shied away from offering repeat procedures to patients who had a poor response to their initial procedure. I think the fact is that we have simply not seen many patients do better, in quotes, and I think it's important in quotes, after their second procedure than they did after their first procedure. We just in general have not seen that. Now there are always exceptions, and everybody here treating patients with this procedure knows there are exceptions to every rule that we talk about during the course of this meeting. But in general, these patients tend to not do better than they did after the first time. Here's a patient, pre and post images from a venogram showing a valvular stenosis at the base of the right internal jugular vein. Look better. He really didn't feel much better. This was, again, early in our experience. We brought him back for retreatment. That's what he looked like. He restenosed, clearly. We retreated him. Slightly bigger balloon, looked better. Still no change in the way he felt. Another patient, lovely woman from Florida, had this pre and post image from her first venogram. She maybe minor changes, nothing too dramatic. She wanted us to retreat her. Pre and post images again. And again, nothing different after the second procedure. And I think that it's something we just have to be aware of and not make false promises to patients, because we see this, we did see this quite often. So that's why in my grid there, I kind of cross off those patients who had initially poor response. So again, in general, we don't bring those patients back too often for a repeat procedure. And that means we're going to be focusing on the patients who had an initially good response to the procedure. Like this lady, lovely woman from down south who had the classic MS hug symptoms, trouble breathing, even chest constriction. We treated her. She got better on the table, did great for several weeks, noticed an abrupt change in her symptoms. We brought her back. That's what her azygous vein looked like when we brought her back. We retreated her, looked nice. On the table again, her symptoms felt better. She was thrilled, and she has since undergone some additional treatment down closer to where she lives in the Virginia area. But again, she's someone who had a good response. We brought her back. There was a definable cause for it, and we think we helped her. I think that, again, retreatment should only be generally considered in patients who had a good response. We believe that the best case scenario that I can tell a patient as to what to expect is what they expected after the first treatment. So I am of the belief that if a patient got 3 good months out of the first procedure, it is highly unlikely that they're all of a sudden going to get a 2-year response after the second procedure. That's just been our experience. It is anecdotal, admittedly. I just don't think that we can promise people that we're going to do the same thing, maybe slightly more aggressive, and boom, you're going to feel great for the next 5 years. That's just not reasonable to offer a patient. And so as a general guide, we tell people best case scenario is what you got after your first procedure. Okay? So obviously, what about imaging? And that has to be a question that a lot of you are asking. And if I'm being honest, I'll tell you that we're finding that imaging really doesn't always enter into the decision-making process. A lot of us here are radiologists, and we kind of grow up in the world of imaging, so it takes a little bit of a leap to step back and say, maybe the imaging isn't that important. But that's what we're finding in day-to-day practice. So we do not, emphatically do not offer repeat procedures for patients who had a poor response after their initial procedure, even if the imaging findings are abnormal. Okay, we try to not do, I'm not saying we don't get patients who convince us to give it a try, but in general, that's our algorithm, that's our approach. In addition, we do not offer repeat procedures to patients who are still experiencing a good clinical outcome, but on follow-up imaging, they have abnormal findings. So if a patient goes somewhere and has an ultrasound or an MRV, and it just doesn't look so good, and we get a call saying, oh my God, my veins, they're terrible, I had an ultrasound, what do I do? And my first question is, how are you feeling? And if they say, I'm feeling okay, I said, take a deep breath, and let's just keep following you. I don't think that we should be in a point of treating pictures right now. We should be treating patients right now, and it makes a very big difference. So let's go back to our little square there. And I think the patients who come in with recurrent symptoms, they had an initial good response and they have abnormal imaging. Those are the questions where I think, those are the patients, at least right now, that I don't have too much of a question about trying to go in and seeing what's going on and seeing if we can improve that situation for them. Those are patients that we are retreating, and that's the group that we're looking at. Now, the other group, the patients who had initially good response and now have recurrent symptoms, but their imaging is normal, those are patients that are kind of tough right now, because I'll be honest, I'm not 100% sure how best to handle the imaging and whether or not I should trust the imaging. I think more correlative work needs to be done. But at the end of the day, those patients are often patients I have a discussion with about conservative management. So I tell people, look, I know you had a good response. I know the ultrasound looks normal. I know you want to be retreated. Why don't you just give it some time? This is a developing field. People are working hard to answer these questions. New devices may be on the horizon. And the last thing we want to do is burn bridges for you. So if a patient can handle that, then what I often recommend is just sit. Let's just follow you. If your symptoms really dramatically worsen, we can always bring you back and treat you. But for now, as long as things stay reasonably stable or only mildly progressive, it may make the most sense to just wait and not burn a bridge for future treatment. So that's the conversation we have with many of those people. So once a decision for retreatment has been made, I think imaging is helpful at determining if the procedure is feasible or not. So remember, you've made that decision based on their response, and now maybe imaging can help. Ultrasound is a reasonable imaging exam to do to determine if the IJs are patent, although it's not perfect. Here's a patient we treated. You can kind of see the stenosis down low. We treated her. The post-angioplasty picture is there on the right. I'm sorry, it's right here on the down here. So you can kind of see the, that's all right, I don't need the pointer. You can see the response to angioplasty there. We were pretty happy with the response that this patient had to angioplasty. She came back really a couple of weeks later. She said that she was able to lift her leg in the recovery room. She hadn't been able to do that. She was very happy. A couple of days later, her response went away, but she was really persistent at wanting us to take a look. We brought her back to our office. She lived reasonably locally. We did an ultrasound, showed a patent internal jugular vein, which we later learned was a patent anterior jugular vein because it was a pitfall in the ultrasound imaging, and this patient's jugular vein occluded. So ultrasound is good, but not great. And lately, I've been liking CT venography for some of these more challenging cases. I think, I'm not saying that it's the best diagnostic tool in the world, but I think for real challenging cases, patients who've been intervened on before, and there were really questions about what the venous anatomy looks like, I find CT venography to be great. And I know that the images are small, but basically jugular vein here, no jugular vein there. And you can kind of see the point here, which the jugular vein occludes and collateral start kind of sprouting off of it. And this is a patient who I said, look, your vein's occluded. I think we can bring you back and do another venogram, but probably low likelihood that we're going to be able to get in there and help. Another patient we just recently saw a couple of days ago, again, kind of same thing. Jugular veins on both sides are just out. And you can see the carotids down here. If you look up high, you can see the jugular veins being quote-unquote pancaked by the transverse process of C1. You can see them come down here. And right around here, you can see the prominent external jugular veins arising from the internal jugular veins, and the veins are occluded below. So I think, for my own purposes, when I know someone has been treated before and they come to me and I don't have a great handle as to what was done, CT venography has been a great troubleshooting tool for me to decide if repeat venography is really worth doing. These are not straightforward cases. And so I think when you take on patients that have been treated before, that's the generic statement I can make, is that they're just not that straightforward. You know, many patients don't respond the way we think they should respond, or don't respond the way they did after the first procedure. Here's a patient that was treated outside of our institution. We got into the internal jugular vein down here low, but could not get into the mid portion of the internal jugular vein. We got into the external jugular vein. We were able to get all the way up here into these more superficial veins, but never could make our way into the internal jugular vein. Ultimately, we did. We did find our way up through the internal jugular vein, up toward the sigmoid sinus. And we did this again early on. We were aggressive. We stented the patient. Now, one would think that the patient presented like this and walked out of our place like this and had an ultrasound several months later which showed continued patency of these stents, but never responded the same way as they did after their first procedure. First procedure, they did great. Second procedure, no change at all. No clinical difference for the patient, in their opinion. Venous occlusion is a possibility. I think patients need to know that. They are always surprised. They always say, but wait, but you guys have done venous angioplasty for a long time. I heard it's no big deal. I heard it's, you know, not really risky. What do you mean my veins occluded? These veins occlude. You know, we do angioplasty in these veins. We create an intimal irregularity. We change the thrombosis dynamics and equilibrium there, and they are at risk for thrombosing their internal jugular vein. It's incredibly important for patients to know that. Okay, and it's also incredibly difficult to recanalize these veins sometimes. Everyone likes to consider themselves a cowboy and a hero, but it's not always easy to get through these veins. And in fact, oftentimes it's quite difficult. Here's a patient that came down. This was the original treatment. Okay, we dilated her left internal jugular vein. Patient came back. We could not get into the left internal jugular vein. Okay, so lately, to be honest with you, in those particular cases, sometimes I try and go like this and do a venogram from there. And the reason why I do that is that's the best way for me to see what's going on. In the absence of a good CT venogram, I can start getting pictures like this. I can see the sigmoid sinus come down. I can see the internal jugular vein come down. I can see the anterior jugular vein filling this way. You can see that right here. I can see the external jugular vein filling here. I can see the base of the vertebral vein filling here. The only thing I can't see is right here, the internal jugular vein. We tried to get in and we couldn't get in, but at least I had an answer for this patient. And it's incredibly difficult during venography to get this answer unless you have what's essentially a physiologic look at what the venous drainage looks like from this patient's brain. Aggressive treatment is possible, but setting limits is recommended, strongly recommended. Here's a patient very early on in our experience, one of our initial patients. This is what we treated, looked reasonably good pre and post. She came back with recurrent symptoms. Her vein was occluded. I do find that when we do primary procedures and we see a very prominent anterior jugular vein like this, that's providing a lot of outflow from the internal jugular vein, that sometimes aggressive treatment in the veins doesn't do so well. That there's competitive flow, and that this is a low pressure system, a low flow system, and that when you have competing veins providing outflow, you sometimes don't have such good outcome, and this lady occluded right here. We did have enough vein in between her mandible and the point of occlusion that we were able to get in from above. So I know part of my talk is supposed to be on bailout. I'm not really so sure that we should be thinking about bailout in these patients. I don't know if we know enough to be appropriately aggressive in these patients. So I think staying conservative makes more sense. Again, this is early, but we did go in here, we punctured here, we were able to get through the occlusion from above. We dilated it from above. That let us get a catheter in from below. And once we got in from below, we were able to stent her. All right, so we stented her. Her stent occluded on the next follow-up ultrasound exam. And I think some of that may just be due to the competitive outflow and the prominent collaterals that existed in her before we even got started. Another patient, just similar, pre and post, she occluded as well. In terms of bailout, we got in from above. Look at that. Again, a prominent anterior jugular vein providing competitive outflow. We did get in, we did stent her. Her stents are doing great, but clinically she has not had any improvement, at least not to the degree that she had after her primary treatment. So it's tricky. And I think that in conclusion, I acknowledge our system is not perfect. It is a system, it is not the system. So we may be missing some patients who might benefit from a repeat procedure. I acknowledge that. The problem is that right now there are too many patients that either report no improvement or only brief improvement after primary procedures, and I don't think it's feasible right now to perform repeat procedures on everybody, and nor is it safe to do repeat procedures on everybody until we have a better understanding of who might best benefit from another look at their internal jugular veins. So my recommendation is to be conservative when it comes to secondary procedures in this patient population. Remember, it cannot be emphasized enough. There is no data supporting secondary procedures right now in these patients. At some point, an aggressive approach is likely to do more harm than good. And so now I believe strongly that the response to the initial procedure should be the guide and should play the most important role in deciding whether or not you offer a repeat procedure to a patient. Thanks.